So my talk today will be about antibiotic stewardship and what we hope to achieve in the next years. Those are my disclosures. We all know that we're standing at the critical point in medicine where antibiotics do not work anymore. We have a lot of antimicrobial resistance, and the power that antibiotics had in the previous year is not the same anymore. So, and in my next 20 minutes, I'll give you some ideas of how we can improve antibiotic stewardship, not only to make antibiotics better, but to save lives and protect modern medicine and protect our patients in the future. Let's see what is happening up to now with antibiotic resistance. By 2019, 5 million deaths were associated with antibiotic resistance. And if we don't do anything in the next years, by 2050 it's projected that 10 million deaths will be from antibiotic resistance. So stewardship is very important, and we have to take a close eye on it. We should not see it as a restriction. We should see it as optimization. And what do I mean by optimization? Giving the right drug to the right patient at the right time and for the right amount of time, for the right duration. This is the global trend. Antibiotics, 16% of antibiotics were consumed between 2016 and 2023. If nothing is done again, the projection tells us that 52% increase will happen by the year 2030. And what I want you to realize here is that from all the antibiotics we're using, 73% are used in animals and in agriculture. So why stewardship is very important? Because all the studies are telling us that 30 to 50% of antibiotics are prescribed inappropriately. And what does that lead to? It leads to antimicrobial resistance. And that leads to longer hospital stays and eventually increased mortality. So preserving antibiotics is very vital for the future of medicine. And what have we done so far to increase stewardship? The World Health Organization has come up with a WHO-aware classification of antibiotics, and it has grouped antibiotics in three major categories: the access, the watch, and the reserve category. The idea is to use antibiotics when prescribed predominantly from the access category. The access category includes antibiotics of first and second choice antibiotics that have a little tendency to become resistant. The watch group is the one we need to have stewardship because they have a higher resistance potential. And the reserve group is the last resort we have, and we should protect them as much as we can. And since 2015 this came up, let's see what we've done so far. We have improved a bit, especially in hospitals. Most of the hospitals in the States and in Europe, they do follow either the CDC or the WHO core elements. In the US, for example, the year 2022, most of our antibiotics that were prescribed were from the access group, and it was over the 65% that the WHO suggested. And we see that on the global trends and on the map on the right-hand side. We do, however, have problems with prescriptions in the community and in the outpatient clinics because we realize there are still a lot of misuse in that areas. And the problem with the antibiotics that are used in agriculture and in animals is still very high. 70% of antibiotics are still used in those domains. And the progress, unfortunately, is very small when we talk about low and middle-income countries. For example, in India, 60% of antibiotics that were prescribed in hospitals, they were from the watch and the reserve group. So there is a lot of work to be done. And let's look at this graph as well. We see how in hospitals, although there is improvement in stewardship, we're still in hospitals who are using the reserve and the watch group to treat infections in the hospitals. We see blue is the watch, so there is a lot of reliance on the watch group to treat infections. We should go towards the access and reduce all the other groups. So to improve stewardship, we have to overcome all these challenges. We do know, and statistics are telling us, that antibiotic consumption has increased from 29.5 million to 34.3 billion defined daily doses between the years 2016 to 2023. Misuse and overuse is still there. Empirical broad-spectrum antibiotics are used by doctors to treat infections, especially in outpatient clinics and in long-term facility centers. The WHO classification is still unmet in many, many countries. And this is because to very limited resources they have. There is also diagnostic uncertainty in certain places where they lack quick diagnostic methods, so the prescriber is resistant, or because he has fear of under-treating the patient, to choose from the watch and the reserve group when he prescribes or she prescribes. The patient, most of the time, demand antibiotics because they're not well educated. So we have to take care of that aspect as well, because we have inadequate outpatient stewardship. In that section, the stewardship is very, very low. So for the future, let's take small and practical steps. The first thing we should do is to expand stewardship not only in hospitals, which we've seen it has started to work, but in the outpatient clinics and in the long-term facility centers. We should incorporate stewardship into medical education. Our young doctors, they should know to prescribe with caution and to prescribe right, so in order to save the antibiotics for the future. And also we should establish global antibiotic benchmarks. Every country, even the low and middle-low countries, with our help, can use the AWARE classification and use antibiotics from the access group. And because antimicrobial resistance knows no borders, we should foster international collaborations and data sharing. That will help us establish where we are and how we can improve. And let's see how we can do that in places where stewardship does not exist. They could use the CDC core elements of antibiotics program, stewardship programs. And they can use quality improvement if they have it. But where the most effort should be drawn in is to the outpatient stewardship. They should make sure that the outpatient clinics and the long-term facility centers be educated more, do a more rational, the doctors there do a more rational prescription, and educate patients as well, so they don't have to reduce demand from that side. But in our tools nowadays, we have artificial intelligence and big data and rapid diagnosis. We should use all of them to improve stewardship in the places where we have it and introduce in the places where they don't. Artificial intelligence can help us to identify new antibiotics, to support this clinical decision-making by using the electronic health records, and that way we can predict sepsis or other infections and prescribe more cautiously. Big data and machine learning will predict resistant trends, not only locally, but it could be regionally or global, and that will create surveillance dashboards and will guide empirical therapy and the policies that will come out of that. And of course, where we can, we should have in our centers a point of care molecular assays as much as we can, so that we can detect pathogens fast and the resistant strains, so we can direct antibiotics to the right direction and reduce the broad-spectrum antibiotic use. But stewardship as alone is not going to work. We have to collaborate with other technologies that they exist and with other scientific efforts to reduce antimicrobial resistance. We do know that there are strategies, future strategies, that they're trying to reduce antimicrobial resistance by introducing bacteriophage therapy, viruses that attack multi-resistant microbes and biofilms, by introducing and enforcing vaccination strategies by law that will prevent bacterial infections and reduce antibiotic demand, by modulating the microbiome so we'll have a pathogen that is not colonizing, and with combination therapies with adjuvants, where we pair antibiotics with resistant blockers. So when we talk about stewardship, it's not a one thing. We should talk about the new technologies, and we should talk about the new technologies in pathogens, in attacking microbiology resistant. And also, that what is very important is to see the antimicrobial resistance through one lens. And what do I mean by that? As I said from the beginning, 70%, over 70% of antibiotics are used in animals and in agriculture. So in order to have a good stewardship for all antibiotics you use, we have to make a joint effort. It's not only a medical problem. It's not a human problem. It's a human problem, it's an animal problem, and it's an environmental problem. So we have to do combination of our strategies, to combine our strategies on how to improve antimicrobial resistance and make stewardship better for all sections, and for humans, and for animals, and for the environment. So, in conclusion, it's definite that antimicrobial resistance is a defining challenge in the coming years. The future direction that stewardship should take is to involve rapid diagnostics more in as many centers as it can, to involve artificial intelligence and big data, to have in place the new antibiotics and enhance the research of new antibiotics and alternatives, introduce policy and incentives, and have the One Health integration, involve animals and environments in the whole process. And in order to succeed, we need innovation, we need education, especially in medical schools and to the young doctors. We need collaborations from everybody, across the borders from every country, and we need strong leadership. Because antibiotic stewardship is not a luxury, it's a necessity. And the choice we make today will lead the future tomorrow. So together and with collaboration, we can make sure that the legacy of antibiotics is one of survival and not of resistance. So we should preserve antibiotics as much as we can, and that way we can protect our future. Thank you.